What's up, YouTube? Just wanted to make a quick video. I got a question that I thought would be relevant to a lot of people, so I wanted to just answer it on a video as opposed to typing it in the comments, so I don't have to type it in the comments for like 10 different times. This guy Bartlett Wu, or Bartek, sorry, Wu, asks what is a simple decompression without transposition, and then he's asking about degrees of severity and so I thought what would be easy is to just talk about all the different surgical methods for treating cubital tunnel. And we can start with the simple decompression without transposition, or it's sometimes called cubital tunnel release, cubital tunnel surgery, in situ decompression or something. There's also an endoscopic decompression. So let me just explain what the decompression or release is. Basically, they're going to make an incision like where mine is, and they're going to release all of the potential points of compression, starting with there's something called the arcade of Struthers, and there's a bunch of different ones that come down. Then there's the cubital tunnel right here, and then some that kind of go down into the forearm. And the reason for that is if there's compression in here, that can be causing the tingling and the pain in the hands and pain in your elbow, forearm areas. So most people that they recommend that for, that's the least invasive. Some doctors will say, oh, I want to start with this because this is the least invasive. The other type of decompression, so with that one, they make an incision like this one, and sometimes they make a bigger incision, sometimes make a smaller one. It's all surgeon preference. Some like to have it more open, I guess, and my surgeon tends to make the smaller one, and I'm sure he just kind of pulls the skin around so that he can see and feel where he needs to. But there's another one called an endoscopic decompression, and basically they use an endoscope, which is kind of like a tube with a camera on it, and they make a tiny incision. I mean, it's real small, and they basically decompress up there and decompress here. They decompress all the same areas, so that's actually a pretty good option if you only need a cubital tunnel release or decompression. In my opinion, it is a little bit more risky in the fact that they can't necessarily see as well as when they have it open, because they're just looking through the camera of the endoscope. But they do arthroscopic surgery on people's knees all the time, and that's probably just as tight area to operate, and they seem to do fine with that. So if you guys want to consider that, that's an option. And again, usually the people that are going to benefit the most from decompression or release surgery are just people that have compression problems. They don't have a subluxation of the nerve. If your nerve is unstable, which it's popping over this, might be easier to show right here. If it's popping over this bone right here, your medial epicondyle, if it's coming over like this, I've showed you guys how to sort of test for that. If you feel that, or that's something that you think is happening, decompression or release probably isn't going to work very well for you, because once you decompress this area, the nerve is going to move even freer. If it's compressed, it's sort of kind of getting pinched down in there and held there. But, common sense is once this is freer to move, it's going to move where it wants to move. And when your arm is bent, in the natural position, your nerve just wants to find the shortest distance between 2 points. So that's why it pops over there. But some people it works fine with. So you just need to understand with your surgeon or doctor, whoever, if you have subluxation or not. So that's why I always tell you guys to try to figure that out. That'll help direct sort of what might help you the most. The other type of surgery, there's a medial epicondyle. That was one of the surgeons I met with, recommended that. For those of you who don't know, I met with probably, 6 or 7 surgeons, and at one point, it was like every guy I saw had a different idea on how to treat it. It was like this guy wanted to do a endoscopic decompression, this guy wanted to do submuscular transposition, this guy wanted to do subcutaneous. It was just everything. So one of the guys wanted to do a medial epicondyle. That's the same thing. They do the decompression part of it, the cubital tunnel release part of it, and then they shave down this bone, your medial epicondyle, so that if the nerve subluxates, it can glide over it without irritation. And that sounds good in theory, and maybe some people have good results with it. Obviously, some doctors treat all their patients with that, and it does meet the quote unquote standard of care. But a lot of the surgeons that I met with cautioned me about that one, saying that by shaving the bone away, there's a lot of residual pain after the operation with that in regards to that, and maybe it lasts longer than it needs to. And really, if you have subluxation, the transposition is probably going to be a better option anyway. And then, the way a friend of mine who is a doctor explained it to me, he said, you can always cut muscle or tissue and sort of go and undo that or stitch it back, or, it might not be as good as it first was, but you can always repair that. If you shave bone away, it's gone. There's not really anything you can do to put it back. So that kind of stuck with me. And from what I saw online, I rarely saw anything about a medial epicondylectomy, so that kind of stuck out of my head. If I'm reading research journals about the best outcomes for cubital tunnel surgery, and I'm not seeing that at all, there's probably a reason for it. There's probably a reason a lot of doctors choose to do the other thing. And the transposition is more probably takes more skill to kind of do anyway, so it's not like that one's more complicated, and that's why they don't do it. So anyway. So then there's the transposition surgeries. There's a subcutaneous, which is what I had. Again, it's a lot of times it's referred to as a cubital tunnel release with transposition because they do the same decompression, the same release surgery they would do if they did without the transposition. In fact, when I was in the prep room for my surgery, I didn't even know if I was going to get a transposition because my surgeon basically said, well, let me go in, I'll decompress the area, I'll release all the places that possible compression could be causing problems, and then I'll bend your arm and I'll take a look and see how stable your nerve is. And of course, when he did that, it was popping over the bone even just as much, so he went ahead and did the transposition. So again, with that, they decompress here, incision, and then they move the nerve anterior, which basically means just from here, from the back side to the front side, over the medial epicondyle so that it's not popping over that bone when you're straightening and bending your arm. Now, there's different ways they can fasten it in the new location to keep it there. One is with a fascial sling. My doctor used what's called an anti-brachial fascial sling. I guess it's not quite as rigid as muscle fascia, because one of the cautions with that is you can't make the sling too tight because it can become then a secondary site of compression. Just you released all these and now you have a new one. But it has to be tight enough to keep it in the right location. I think mine, I can't see inside my arm. He doesn't know. Mine's either broke, maybe I went back to doing stuff too soon, which I don't really think so, or mine's just loose enough to where mine kind of pops back over if I totally straighten out my arm. Now, it has gotten better since I'm aware of that. I don't really walk around with my arm straight out like that or anything now. And just knowing that that's the thing, and again, I used to sleep with my arm straight, kind of pinned underneath me. Not doing that helps tremendously. So I can pretty much do everything in my normal day and never have any kind of symptoms in my hand. I go to the gym and do all that. Very rarely does that irritate it. Maybe if I did like 6 sets of heavy deadlifts or something where my arms are really being pulled straight, I might feel sorry, excuse me, something slightly afterwards, but nothing bad. I've been playing guitar a little bit more to try to see how my left one's hanging in, and I do sometimes notice that after playing guitar a while, this one, it's more sensitive. So a lot of you guys, so when they move it over, the subcutaneous, sorry to get off topic, just trying to interject my own sort of narrative so you guys can understand. When they move it over, it's subcutaneous because it's under the skin. They don't put it under the muscle, obviously submuscular. So subcutaneous, the nerve just sits on the skin. One of the questions I get asked very frequently is how sensitive is this area to touching it or whatever. I can do this, I don't have any symptoms. But sometimes if I knock into it, I can get a little tingly feeling. I can tell that the nerve is sort of right there. And I notice that if I play a lot of guitar, it seems to be more sensitive. So maybe that's just the picking and all that stuff, kind of does whatever to the nerve and then makes it sort of more hypersensitive. But I definitely notice that if I play a lot of guitar and then I just happen to brush against something with my arm, I feel it more than if I haven't been playing guitar and I brush against something, I wouldn't feel it at all. So it's just something, subcutaneous transposition for people that have subluxation of the nerve is probably going to be the best bet. Of all the medical research I read, it seems to have just as good outcomes as the submuscular, as long as you're not doing, if you're not like playing football or hockey or wrestling or something that's really like high impact, like contact sports, or you were like an MMA fight or something, then you probably would want to get the submuscular transposition, which again, same incision, they decompress this area and then they move it over, and the only difference is instead of leaving it under the skin, they put it under this, you have a flexor pronator forearm muscle here that attaches at this bone. They cut that, they put the nerve underneath it, and then they close that muscle back up. So you don't need the fascial sling or whatever because the muscle holds it in the new place. So it's very protected. It's more protected than when it sits here and it's just protected at the cubital tunnel by the fascial tissue and whatever. It's under a muscle. So that's a good and a bad. It's very protected, but the other part of that is it can be then a new source of compression because the muscle can heal and place compression on the nerve sometimes, or the muscle may have atrophied and maybe it gets bigger and place compression. I don't know, there's a million different things. But it seems to work okay for a lot of people. My surgeon cautioned me about a submuscular and said it was just unnecessary for most people, and he didn't like it. He said he had corrected some submusculars that, and I guess made them subcutaneous after the fact. So, again, it's all surgeon preference, and so you have to keep that in mind. But again, if you're somebody who's like elbowing people or something, you're real into MMA or something like that, and that would be something to consider. You probably should do a submuscular because you're going to need more protection on the nerve. But if you're an everyday person, you're not going to really, there is a chance that you bump into it and it hurts. But I don't think it's really any more exposed than it is in the original area for the most part. And again, like if you're not doing anything crazy, you're probably fine. So that's your options as far as surgery goes. The second part of his question was, can you tell something about degrees of severity? The only thing I can say about that is, when I first started experiencing symptoms, it was really just sort of tingling in my fingers and very mild. And, it was back in 2010 or 11 that I started getting it in my hand, my right hand. And I was playing a lot of guitar. I was sitting like this, I was working at a desk, at a computer. So those things all added together, I think, were what started to cause the problem. Why I didn't have it, these are things that I'd done, 10s, 15s, years or whatever, ever since college and whatnot. So why it all of a sudden started irritating it, I don't know. Maybe age plays a factor in it. I really don't know. I think it just boils down to genetics and when your body decides it's had enough, maybe some people reach that point before others. But yeah, so it was just, I didn't have any loss of grip strength. I still could grab things pretty easily. So that what I would describe as sort of minor. As you get more compression, some people, and that was sort of a gradual of the symptoms coming on and kind of persisting like that and slowly getting worse. Some people, it comes on really suddenly and they have pain in their forearms. They have like no grip strength. Their fingers, or pinky and ring are completely numb. That's an extreme case of compression, and those are the ones that need to be dealt with very quickly. Otherwise, it makes it very much more difficult to have a complete recovery. But, you know, I think for a lot of the people, at least that I see writing into me, it's more of a gradual thing, and it was with me. At its worst, I was having a lot of pain at my elbow, and I think that's indicative, I think, of subluxation. People that usually have subluxation, it seems like, complain about pain at the elbow. You know, I think if it's just compression, you probably have some pain there, but it's probably not as significant as if your nerve is popping over that bone. And of course, I had the tingling, and as my tingling got worse, I just started to feel it all over my hand. You know, I know it's your ulnar nerve primarily provides sensation to these two, but my doctor actually said that it can do the back of your hand as well. So I would get it on the back of my hand and here, and then once you got it on the back of your hand and here, it kind of starts to feel like your whole hand is numb. So at that point, I was like, oh, do I have carpal tunnel too? Who knows? But your ulnar nerve can really mess up your hand, you know. And I would just be mousing, you know. I would just have my arm out mousing. How stressful is that on your arm? It doesn't seem like very stressful. And I would even try keeping it straight, and I would still have the issues. So I think once that nerve is irritated, just like what I was talking about with the guitar, if I play a lot of guitar and then I brush up against it, I feel that tingling more. Once your nerve is kind of in an irritated state, a lot of little things will cause problems. So I think, you know, the fact that I had subluxation, my nerve would get irritated, and then even when I'd have my arm straight out and I'm mousing and it's in a relaxed position, that was before the surgery, that's a relaxed position, it you know, still caused it to feel tingly. That's another thing too I want to touch upon. When you get the transposition and your nerve is moved over here, now your relaxed position is like this, because your nerve is no longer being stretched around that bony medial epicondyle. So I intentionally sleep now with my surgery arm, my right arm, bent, because that gives it a break. If I have it stretched out, then that's actually stretching the nerve out. So that's kind of like the equivalent of being like this with my non-surgery arm. So keep that in mind, because I really didn't even think about that when I had it done, but then that helped my recovery a lot, and it helped minimize the recurring symptoms I was getting in the hand that I had the surgery on. So I know that was extremely long-winded answer to your question, but hopefully I provide you with a lot of information in there to where you can make decisions about what it is you think you need to have done. And these are things that you'll have in your head that you can then discuss with the doctor, because that's really the point of this, is so you understand it. So if the doctor tells you one thing, you can know whether or not that might be the fit for your situation, because no one's going to care about your health as much as you do. So that's really the goal with all this, is to empower you guys to take control of it and find the relief that you're looking for and the best situation possible. So again, thanks for all the helpful comments, and keep the questions coming, and I'll continue to answer them, and I hope you all are doing well. Aloha.